today's discussion on the topic of care, support, and treatment of people living with HIV, a collaborative approach. Let me begin by introducing myself. I am the moderator for today's panel discussion, Dr. Siona Gomes, a consultant radiologist by training with a long innings with the DHS, and now I'm serving as a deputy director under the DHS and on deputation to the Goa State AIDS Control Society as its project director. I'm proud and blessed at the same time to have with me eminent doctors. Dr. Edwin Gomes, Professor and Head, Medicine Department, Goa Medical College, also a Nodal Officer for ART Center at GMC. Dr. Rajesh Naik, Consultant in Medicine and HIV, Private Practitioner based in Margao. Dr. Manish Gaunekar, State TB Officer under the DHS. Dr. Philomena D'Souza, ex-professor and HOD, Department of Pediatrics, Goa Medical College. To begin with, let me share a brief outline and background and the objectives and goals of this initiative to our viewers. NACO is a parent organization under the Ministry of Health and Family Welfare, who is the main guiding force for the state AIDS control societies across India. Starting first with the first 5-year NACP Plan 1 in 1992, presently we are at NACP Plan 4 from the year 2012 and 2017. At the moment, we are guided by yet another strategic plan from the year 2017, which will run up to the year 2024. Recently, we have received the HIV estimation surveys of 2019. In Goa, the rate is 0.03 per 1,000 unaffected population, and the HIV prevalence is 0.27%. In the last 5 years, the new infections have remained steady, around just below 300, and we would want to see this further decline. Well, to take this forward with the aim to achieve the Sustainable Development Goals and to eliminate HIV AIDS by the year 2030, one of the strategies is to engage the private practitioners who could be treating or encountering people living with HIV in their day-to-day practice. Here again, multi-sectoral engagement is a key component of the NACP 4, and such a collaboration does exist with other bodies like the Federation of Obstetrics and Gynecology Society of India and other ministries under the Government of India by way of Memorandum of Understandings. This is a small beginning to this engagement amidst the COVID-19 pandemic, a deterrent to hold CMEs or workshops, and hope to come to some common ground as to the care, support, and treatment of people living with HIV in the state of Goa. To begin with, Dr. Edwin Gomes, Professor and Head, Department of Medicine, Goa Medical College. He has been on the forefront of dealing with the COVID-19 pandemic, and he is here with us today as a Nodal Officer of ART Center at GMC. As NACO has recently has adopted the test and treat policy in the year 2015 and rolled out the same in the year 2017 in the state of Goa, I would like you to share with our viewers how does the treatment initiation happen, what are the protocols, and what are the guidelines moment a person is tested HIV positive.
Thank you. And to start with, if anybody is tested as HIV positive, be sure that his confidentiality or her confidentiality will be maintained. Don't be scared that your confidentiality will be shown to others. Well, we have guidelines. They are all laid by NACO. So if you are tested first time positive, then we have the ICTC center. Then we do another confirmatory test and we find out whether you are HIV-1 positive. Sometimes you could be HIV-1 and HIV-2, and then HIV-2 confirmatory test again is done at our microbiology center, and then we have to take a different stand in the treatment. So once a person is detected to be HIV-1, We will not talk about HIV-2, we'll just stick to HIV-1. HIV-1, remember, is a little faster growing HIV virus as compared to the HIV-2, which lingers on for 2-3 years and then starts causing problems. So we'll talk more about HIV-1. Once we confirm that a patient is HIV-1, then we have an extensive list of things that we have to ask. The history, medical history, the various tests that we do, tuberculosis history, whether the patient has got tuberculosis, any other STDs, allergies, vaccinations, what medications the patient is taking, the obstetric history if the person is a female. The psychosocial history becomes also important, and the functional status. Now this is because the patient is coming for the first time. A lot of time is spent in this history taking. We have good counselors outside, the NGOs are staying outside, and all this is done. Once this is done, then the physical examination is done. Lymph nodes are looked out for, and since India is very, very prone to tuberculosis, we look out for these lymph nodes, and then we look out for any evidence of tuberculosis or any evidence of any other opportunistic infection. Why, I'll be telling you in a short time. Then we stage the patient, and usually the patients come to us in stage 1 and stage 2. If the patient comes in stage 3 and stage 4, believe me, he will be not coming to the ART center, he will be coming to the ward. He will be a person, or she will be a person who is diagnosed after admission, because there you have very severe weight loss and some OI will be there. So these patients usually come into the ward and then are found to be HIV positive. So the HIV that we see coming to the center are usually stage 1 and stage 2. Under the latest guidelines, we are supposed to start them on treatment immediately, irrespective of the count, no?
Yes.
Irrespective of the CD4 count. So the treatment that is started is a fixed dose combination that we have. We have stocks of it. We are not running short of that stock, and it's TLE and TLE and TLE only. Well, if the person was taking some other drug, then we continue that drug, but as far as possible, we try to shift to TLE. There are some patients who develop adverse reactions, and we monitor those reactions. We have a white chart to be filled, and on that white chart that is filled, all the investigations are listed. And in that white board that we fill, we don't give that to the patient. The patient gets only a green book. The white chart that is there, on that even how often each test is to be done is seen. Later on, we ask the patients to come for follow-up. Now I'm going to stress why we follow these guidelines. A long time back, we used to get an immune response which was very bad. The patient's symptoms would flare up, or the OI would flare up. And NACO and various higher-ups or various researchers have done a lot of research and have told us exactly when to start the ART treatment. Like in TB, we first give the TB treatment for 2 weeks and then we start ART. Or if the patient is a male, we monitor the patient much more, especially if the CD4 count is low. And I must say, for the last year and this year, we have not got a single case of iris in our nodal center. So the reason why we are doing this test is to prevent iris first, and then of course to start the ART and see that compliance is there with the patient.
So this treatment is sort of lifelong. Once
Yeah.
you are detected HIV positive, you've got to be on continuously treatment. So how does the ART follow up on adherence of the patient?
Very
And
good.
how do you also monitor whether he's really taking medications or he's not responding to this treatment that you've started on?
Yeah. So the first question is how to monitor adherence. That's very easy. You count the number of tablets you've given. You find out how many tablets he has missed or she has missed, and that you calculate as a percent adherence. That is one. Number two is we check the CD4 count every 6 months, and we see if that CD4 count is rising or falling. The moment the CD4 count is falling, before it falls to more than 50%. Sometimes we catch them as low as even 20-30%. Look out for an OI, or look out for HIV-2. Sometimes the HIV-2 may not be positive in the first go, might come later on. Look out for HIV-2, look for HPV, look for HCV. Look for something else that is bringing the CD4 count down, and look for adherence. Now the counselors come into play. The counselors will go and tell these patients, see, listen, if you fail in your first line, you'll be taking a higher pill burden in your second line, with much more side effects. So people understand the importance of the first line treatment, and usually the adherence improves here. The only problem in Goa that we are facing right now, and I think it must be practically in Delhi, in Mumbai, in Pune, Rajesh can tell me later on whether he faces the problem too, is the migrant worker. So people who don't adhere are basically migrant workers. And
so apart from looking at the counseling part of it, is there any test that you do? Like CD4 is one,
Yeah.
so viral load is another one?
Viral load, if the CD4 count is falling, then we do the viral load. We are supposed to do the viral load every year. Mm-hmm. That is another thing that we can
Yes, that's the newer guidelines which
newer
has
guidelines
come.
That we are supposed to do every year.
So that line list does come.
Yeah.
Who is like the next one? Who are due for the viral load testing? So now what I want to know is also, you talked about first line resistance or poor response. So which are the other lines of treatment that Goa Medical College can give?
On the first line only?
After the first line, if that is not working.
Now, the first line treatment I said was TLE and TLE. There is a new drug that is coming into the pipeline, and it's already mentioned. And we are giving TLD as a combination. Though our pharmacologist often laughs at us and says, Dr. Edwin, you are using the D practically everywhere in first line, second line and third line, but that has come as a NACO guideline, and we cannot question people who have done research there.
So you are giving first line, second line, and also there are some people who fail even on the second line. So I think those patients are referred to the Center of Excellence that is in JJ Hospital, Mumbai.
Correct.
So even those drugs also we have made available because of the COVID pandemic. The people could not go and get their doses. So since the start of the pandemic in March, we got these patients transferred to the IRT center at GMC, and now they are availing that even the third line treatment at Goa Medical College. So having said that, there is, as you just mentioned, that OIs, that opportunistic infections are so rampant. So how do you keep a tab on them, and do you have any preventive therapies that are?
Yeah. So basically, in the NACO guidelines, there are 3 preventive therapies that are allowed to be given or that are told to be given. Number 1 is the isoniazid with pyridoxine. That's with my friend Manish, and it is given for about a period of 3 to 6 months. 6 months. Yeah, I know it's 6 months, but I recently got the data from GMC that is released. We're sending you to today. We're getting at least 20% to 25% dropout in isoniazid preventive therapy. INH is 300 milligrams, pyridoxine is 40 milligrams. It's a combined tablet, but I don't know why they are dropping out. I cannot understand there. They are taking their ART treatment, but they are dropping out of the INH prophylaxis, and that is to be given to everybody. The second drug that is there is fluconazole. And fluconazole is to be given in those patients whose CD4 count is less than 200, or patients who have got fungal OI. So in these patients, we give fluconazole, and the moment the CD4 count crosses 200, we stop the fluconazole. Fluconazole is tolerated well, and believe me, the patient has a fungal infection, and if you give fluconazole as a treatment also, the CD4 count climbs to more than 200. The third one is the chlortrimoxazole, the CPT prophylaxis that is there. Patients who have got pneumocystis, now we call it pneumonia Jerovici, which you get there, and if the CD4 count has fallen to less than 350, then we give CPT as a treatment first and then as prophylaxis. When you're giving us prophylaxis, you must wait for 2 CD4 counts to be more than 350. So even with fluconazole, when you give, you have to wait for 2 CD4 counts to be more than 200. And here you have to wait for 2 CD4 counts to be more than 350. We've corrected that in the HIV center after I was studying for today's talk. So there are certain things that have come to my mind, and I intend keeping this book in the HIV center.
Yes.
The INH is for 6 months, but we are getting dropouts. The CPT they are taking, it is for 2 CD4s which are more than 350, and fluconazole you have to give till 2 CD4s are more than 200 at a space of 6 months.
Okay, that was a nice elaborate way how the NACO works with the ART centers across India. So now I will like to hear the same thing what Dr. Rajesh Naik is doing. Dr. Rajesh Naik is a consultant in the medicine as well as HIV, and he was one of the few Indians who were selected and the only Goan who made it to USA for a fellowship in HIV. So doctor, thank you for being here despite your busy practice and all the way from Margao. I would like you to share in the same manner how you go out whenever a person comes to you who is tested HIV positive, and what protocols you have in place, and generally why do they seek treatment in private as well?
Thank you very much, Dr. Siana. Actually, I was taken up to this HIV medicine. Actually, I never thought of taking HIV medicine. It was when I joined ESIS hospital. There was a small anecdote which I would like to tell. When I joined ESI hospital somewhere in 1992, very first day when I joined, I had a patient. It's normally in a ESI hospital you have an insurance person and you have the person who is supporting, or called as family member. A insured lady, she was working in one of the resorts in South Goa. At that time, a lot of South Goa resorts were there. She brought her husband, who was on ship, and this man had Fournier's gangrene in Germany. And when he had this severe, he was on board developed Fournier's gangrene, was admitted in Germany, one of the hospitals, and was treated for Fournier's gangrene, probably developed a lot of blood transfusions were also given to him. He came back, his company sent him. This lady supported him because their job was such that he was not working on the ship, the salary stops. So this lady supported the family by working in the resort. She was a housekeeping department. And within 1 or 2 months, she conceived. And she came to the hospital. It was my first day as a consultant in this. She had brought her husband for some seborrheic dermatitis. So because she was also pregnant, she wanted her all the tests to be done. So as usual, we rated an antenatal checkup, and that time we had just started this counseling for HIV because this patient had come out from outside India. So a counseling was done, and that time we didn't have our blood tests used to go to GMC, or we used to send blood tests to Basai Darapur at New Delhi. But we had also a point of care system. That time Tridot just had come in the market. So Tridot was a point of care test, and to our surprise, we found that both of them were positive. And she was pregnant, and at that time we never had this drug like nevirapine. Madam will be able to tell us that a single dose of nevirapine could prevent mother to child transmission. It was just 92 that time. And the plight of this, because she was positive, the resort removed her from job that time, and there was no one to support. And then subsequently we started getting such patients again and again. Every house who had someone or the other on the ship or in Gulf, where every person who was to get HIV infection was outcasted. Nobody used to see them. The doctors used to not see him. Even my medical officers who were there were very reluctant to touch them. So this is the point it made me to go closer to these people, because I was the only medical consultant at that time, and see and more about this. As I started reading myself, and then I got more attached to this, and that's how I went into this specialty. They used to always come to us with opportunistic infection. Maybe we used to have so much so this opportunistic infection that most of them, I remember, they used to come with multi-dermatomal herpes zoster, multiple dermatomes involved, or used to have oesopharyngeal candidiasis, or we have had them coming with chronic wasting syndrome or a PUI, mostly they were PUIs, and we had a disseminated tuberculosis.
So basically you were treating more of patients who are in clinical stage 3 and 4. So what is the scenario today?
Now with that, today's things have totally changed. With very good, I should really thank Goa AIDS Society.
So the awareness
is so high, and people no longer they ostracize or no longer say that they are very open, and they come out to saying this, yes, I am seropositive and I want to take the treatment. Now what exactly happens with sometimes about 40% of the people do not want, still as Dr. Edwin says, they have got an excellent system there, but 20 to 40% of people don't want to take the treatment from this. They want a private setup, and some of them they afford. They said, yes, we will afford the treatment, and what we do is we counsel them. I counsel them that, see, this is the drug which is given to you. You will get it lifelong. It's like diabetes, and you cannot stop the drug. And I know, because I'll tell them, because my experience tells about 20% of the people say yes in first, and moment after 1 or 2 years they say they back out. I cannot buy them.
It's enough. They cannot afford
the drug. Yeah. And in that case, then we always tell them that if you don't respond or if you stop the drug, you will go for second line, and if you stop second line, you go to third line. I have got some patients who have taken drugs properly. In spite of them after about 20 years, some of them have gone in for a second line, but they have afforded. But 70% of the people who opt for private treatment, they take it regularly. As we say, we do this adherence test, and we give them a chart to fill their own the tablet charts. Okay. So that when my staff, staff comes, he looks at the chart and tells me what is the solution. Immediately what we do is, in addition to the CD4 count, what we do a viral load, because now viral load has become very cheap in private. So we do viral load every 6 months in these people.
Yeah, nowadays NACO also insists on viral load rather than CD4. If the CD4 is good, they say don't even repeat it, just yearly repeat.
Because there are two things which will happen. One is immunological failure, and second is your cellular failure. Sometimes what happens, our earlier treatment schedule was we used to start ART only when the CD4 count was 350. What mistake we have seen is that your CD4 count may come up, but immunological failure still persists. So they don't feel that good. So if you start as early as hit early and hit hard, they do much better off.
So you said around 70% continue with you, 30% drop off because they cannot financially afford the treatment.
Still we don't tell them.
Do you
I refer them back to
counsel them to go to a government
definitely.
facility?
We refer now the auspicio
because now we have a full-fledged ART center.
Yes, so at auspicio, so I give a personal note.
So do you also do this preventive therapy as or the NACO guidelines says, like for tuberculosis, latent tuberculosis?
Yes. All patients nowadays we don't rely on Madam has taught us PPD, which was I still remember her pediatric clinics about 30 years back, 1980-82, where she used to insist us to give every child PPD those days, and for this bones complex. Nowadays in HIV, Dr. Edwin, this PPD has got not much value, because your immunity itself, cell-mediated immunity itself is down. So you have a better drug now, TB quantiferon. TB quantiferon is a blood test which denotes your something called as ESAT6, or an early secretory antigen, or a culture filtrate protein, CFP, which Dr. Manish will be knowing, CFP10 or TBM 7.7 protein. These antibodies which are produced can be detected by a test called TB quantiferon gold. So if that test comes positive, then that means you are harboring a latent tuberculosis. So we do put these patients on.
So you do evidence-based preventive therapy, not like for us it's a protocol. Like moment after 6 months of anti-ART treatment, you need to start them on this. These are the NACO guidelines.
No, we do this if they are failed, because what happens, we start this ART much earlier, so their CD4 count becomes quite robust. Only problem comes to us is when they come to us in disseminated tuberculosis. In that case, if the CD4 count is less than 50, we can't wait for 4 weeks. We start your ART 2 weeks after anti-tubercular therapy.
Same as
so baseline CD4 count is one thing that you start, but you have to take a baseline CD4 count.
Yes, that is very important.
Just to know which stage your is coming in. Okay, thank you for those very valuable inputs. So now I would like to ask Dr. Manish Gaunikar. He's a state TV officer under the DHS, and this is another program which is working very closely with the private practitioners as to the treatment, the protocols, and the reporting. So, Dr. Manish, can you just share what are the highlights of NTEP? I know you've been fast-tracked into eliminating tuberculosis by the year 2025. So, I think lots in your hands.
As far as the NTP program is concerned, our program was called as RNTCP, Revised National Tuberculosis Control Program. From this year, the name has we are renamed as NTEP, National Tuberculosis Elimination Program. And under the program, we offer services to both public as well as private patients in the form of diagnosis, treatment, and everything is free of cost. As far as diagnosis is concerned, we offer microscopy, we have CBNet, and now we have introduced TrueNet also. 3 machines have been allotted to us. And the treatment, whatever treatment is given, it is free of cost. So we have public as well as private patients. Yeah. And we also have a scheme called as Nikshay Poshan Yojana. Under the scheme, every patient who is put on treatment for tuberculosis is given 500 rupees per month for the duration of treatment. And the amount directly goes in the account of the patient.
Okay. So your treatment is sort of not a lifelong treatment. It is 6 to 9 months or whatever, depending upon the tuberculosis, what type of tuberculosis he is having. So how did you collaborate with the private doctors? Like there were some state guidelines, notifications that made the private people report to you, or you requested them? So because similar things, we need to sort of develop this rapport with the private doctors as far as HIV treatment is concerned.
As far as the private reporting is concerned from private, we have about 30 doctors reporting from Goa. Also, we have about 8 to 10 laboratories reporting, and also all major hospitals are reporting. Now, of course, as per the guidelines, as per law, every private doctor has to report. But we are not going ahead with that IPC 269 to 70. We have 2 PPM coordinators, 2 public-private mixed coordinators, one for North Goa, one for South Goa, who visit the private practitioners who are reporting to us and obtain the data from them.
Okay.
That is one way. The other way is we also have a JEET, Joint Efforts for Elimination of Tuberculosis. So they are also helping us. They are also visiting private practitioners and giving us the data, collecting the data. And also we, as far as the chemists are concerned, they are supposed to, they report from the whatever drugs are sold. So we get that data from, they submit the data to FDA. Through FDA, we get the data, and if that patient is not on treatment as reported, he has not been reported by the private practitioner, we go on the other way, and then approach the practitioner who has given the prescription and obtain the data that way.
Okay, so it's like more of a multi-pronged approach.
Yes,
you are getting the data,
yes,
then you physically collect the data. It's not that you online report it.
Yeah, online reporting facility is also there. We whatever data is generated, whatever data is obtained, we have a software called as Nikshay. So in that we enter the data in the Nikshay, and it is confidential. And of course, the private practitioner can also log in and enter the data. That facility is also option is also available. But we, as far as of now, it is more of the physical data which is given.
So how difficult was this task? Like, was it is it to get the private doctors on board and to have to know the burden of disease in Goa, So
yeah, it has been a challenge. I would say it has been a challenge. It is not that it is not difficult at all. We have very good cooperation from the chest physicians who are reporting, and over a period of time, this notification from private has increased, As of now, our target for this year has been 3,200. And among them, the target for private reporting from private is 800. Of course, because of the pandemic, it is quite low. Now, hardly about 250 to 260 have been reported from private practitioners.
Because your people don't come now.
Exactly. And last year, it was almost 500 to 550.
Every first week, first Monday, your man is to record to our clinics and is to take the record. Last 3 months, he has not come.
I also think that because most of the chest physicians have come out through Goa Medical College, and most of them are now the young chest physicians.
Yes, sir.
And they were involved in the RNDCP.
Yes, sir.
I think the notifications have improved
as
compared to what was happening before.
Yes, sir.
Under the NTP, he has managed quite well, and the people, the private doctors also are receptive to this idea of data sharing.
Yes,
so it is going on very well. So far as of now, we have just talked about what the adult PLHIVs are like, how we are dealing with them. But in the context of HIV, we have also children living with HIV. And under the NACO program, anybody infected with HIV who is below the age of 15 is considered as a child PLHIV. So I have with me Dr. Meena D'Souza. She's been the ex-professor and head of the Department of Pediatrics from the Goa Medical College. We all know as Dr. Meena. She has been more busy now post-retirement, and she is readily embracing so many other causes. She is into palliative care, but she has a very compassionate heart. Her heart reaches out to the children with HIV so much so she even offered a shelter for these children living with HIV. So madam, children are special, they have many special needs. So I would like you to share what are the special needs of children living with HIV as far as counseling or adherence to treatment is there.
Thank you, Siona. Right at the outset, I need to emphasize one point, that children all over the world share universal needs. And these needs are for survival, protection, to grow, develop, mature, and also to participate and finally become adults who can live a full life. So these are the needs, basic needs of all children. Children who are with HIV AIDS will have extra needs over and above that. And these needs have been very well addressed under the NACO programs. But it's important to involve the private practitioners, pediatricians, and others to strictly adhere to the standardized protocols and procedures. This is very important. Now, because children don't have much of a voice, many times the parents and the other family members or the caretakers may not be able to ensure that compliance is there for the treatment, for the follow-ups, and over the years it has become obvious that with women also going out to work, children being left in the home or going for tuitions after schools, the need to have special clinics at different timings for them has arisen. Now, this may not be possible in a medical college or in a big institute, and that is why the interest being shown now by NACO to involve the community and private practitioners, I think is very crucial if we are to see this generation of children who are affected with the virus, if we are to see them go through life taking their medications every day, because without strict adherence, there is a big problem. And I think over the last 35 years, we have seen the success of ART if given to children.
Correct.
Right? Because it has converted a possibly lethal, fatal prognosis or outcome to one where a child who can take the ART can live, grow, and be normal within inverted commas, like any other child.
Yeah.
And so they have a chance for a future.
Yeah.
And this particular point has to be made not only to the people who are looking after them, but the children themselves.
Mm-hmm. Like a positive feedback, like there is life even if with HIV.
In fact, we have a special OPD on Friday morning for these children, and the Yuva clinic is there for counseling. Plus, the counselors are separate for the children.
From the NACO viewpoint, we have been quite successful in eliminating the transmission from mother to child.
That is done.
So that is really going through for the last 1 year.
But
we
what
didn't
about
have
the
a
children
positive.
who have got?
Yes, that is there. So now, even the ART center can have madam, you must be chaperoning the children into the ART clinics. So anything that more ART child-friendly services that you would have, you want GSEX to reach out in a more better way than what is already happening today?
Let me correct you on one point. I don't chaperone anybody for any treatment.
Okay.
I will inform them what are their needs. They need to be convinced that it is important for them to go to the hospital and take advantage of the examination, the clinics that are there, counseling that is being given, and take the treatment which will be beneficial to them. We cannot force them into it. Number two, I had just begun to tell you what the normal children and children with HIV AIDS who have needs, extra special needs, need to be looked at. But the various other concerns. And right now, yes, as Dr. Edwin said, educational, I agree. But first comes education of the community at large. That HIV AIDS is a disease very much like other diseases, TB, for example. Now we have the coronavirus infection, which is creating fear and anxiety. And actually, they have forgotten about HIV AIDS in this corona epidemic.
Very true. Very
okay? But many people have to be educated on this because there is prejudice everywhere. Amongst professionals, sad to say, amongst doctors, it is still very much there. Till today, I have a big problem on where to take my patients who are HIV positive or AIDS if they have an abscess for an incision and drainage. If I have a woman who requires a hysterectomy. Because professionally, there are many doctors, though they have been educated, gone through all the training programs, they would rather say, no, we cannot do this, you send somewhere else, or it's not necessary. So I'm very hurt actually and upset about this attitude. But as you said, Edwin, education has to be done. And I now educate the patients to fight for their rights. You see, you cannot deny the patient. And our children, if armed with this knowledge, and their families, and moreover the community, if you tell the community that this disease is a disease where all of us have to work together like in any other condition, we can overcome all these prejudices. It is those children who are living in the community, hidden. Hidden means their diagnosis is hidden. They go to schools, but everybody will find out sometime or the other. And so these children are the ones who are being isolated. They are made fun of. They are deprived of so many activities. They will not be taken into sports. They will not be taken into cultural activities. So otherwise, we are ostracizing them. Now, this has to stop. This has to stop. Yes. And it can only stop through the powerful means of education. Understood?
Yes, we are with the youth, we are with the education department as far as adolescent education program is concerned. We are with the youth with the Red Ribbon clubs that are being there. So, I mean, that much of engagement with the youth and the education sector is happening.
Madam, I feel last 3 or 4 years, the things have changed to some extent. At least I see it. Earlier, nobody used to they used to see to it that they used to ring me late in the night. These things which only with education. Now, the one thing I should really compliment Goa AIDS Society is the amount of counseling and information and education you people have done through the schools, through this. Now, no longer, I tell you, because I even see the patients coming directly walking in saying with the report that I am. So it's the things have changed.
Things have changed, and
it has definitely changed.
So it's a good outcome for the National AIDS Control Program. Also, because even the incidence has come down so much. The prevalence has come down by 86% from the very peak in the 1997-98. So there is a, like for new infection, definitely there has been a change in behaviors of the people concerned. So we are like there, but now the last mile is there, 2030, a decade now more towards working towards elimination of HIV AIDS as per that thing. So now
May I add one more thing?
Yes, ma'am.
Now, GSACS has also a responsibility, all right, to ensure the other needs of these children,
Okay.
all right. We've spoken about educational. There has to be vocational training, guidance. GSACS has to ensure that all schemes that are there are applied to these children. All of us forget the fact that there is a very big lacunae of emotional and psychological support for these children. And this is this is responsible sometimes for their wayward behavior, particularly now because we have a huge cohort of young people and adolescents with HIV AIDS.
Yeah, because
We
now-
have
yeah.
not taught them life skills.
Correct.
We've not taught them about sexual and reproductive health. We've not told them how to prevent themselves from being abused and being misused. We've not given them the strength of the confidence to come and approach us when they face these problems. So I think GSACS has to go forward now looking into these needs of the children in Goa. I don't expect GSACS to provide it, but I think you need to make the government and community aware of this so that there is a community response. If there is a community response to the needs of so and so many kids or families in their area, surely we can achieve wonders. We don't have to depend on government.
Definitely, madam. You have highlighted a very important part because now if they can take up some schemes, then they would belong to that above 15 age group. So definitely we can look into this segment of people because otherwise we are only talking of food grains or some other support like, especially if they are in sex work. So that rehabilitation is taught. But this lacuna that you brought to our notice is a very significant population which needs extra care.
It is us as caregivers, caretakers who have to now look at the deeper responsibilities that lie with us to give these children the life skills when they are in the institutions. We have to teach them, we have to guide them, and we have to be there, most important, to support them. Now, if we're not there, they are not going to be able to thrive. And that is why a group of them who are now in their 20s are behaving irresponsibly.
We have got one scheme that is financial support being PLHIVs, that is 2,000 rupees for the dependent social security scheme. So that goes directly to the person living with HIV.
Placement becomes important. So if you have areas or institutions that are doing vocational training,
Correct.
all right, we should also enable them,
Yes.
all right, to do placement.
Correct.
Okay, so you give the incentives or make sure that the already existing incentives are utilized by the public.
Okay.
Which public? The public that needs it most. The kids, the adolescents, the youth.
Yes, we can take this forward, ma'am. It's a nice idea that you put across. So now the goal of this today's discussion was to create awareness as to bring the private practitioners on board to report to SEX. Now what the NACO wants us is that, they want only the provider details. What are the treatment schedules given and what are the response by viral load testing and that they want to happen at a quarterly basis. So the task at hand is to sort of identify who are the doctors who could come on board and report to State AIDS Control Society. So this was a discussion just to bring to the knowledge of everybody how the treatment is happening under the NACO guidance in Goa and where other departments also are involved in taking a very holistic approach to the care of the people living with HIV. So Dr. Edwin, if we get the private doctors on board, what could be the advantage to our program?
If we get I think the private doctors in Goa are on board, at least on the south side, because they have a wonderful network discussion and they discuss with each other by even not visiting each other, they are through a network. But this same model that is there in Margao has to be replicated.
Okay.
Vasco,
Across
Samuel is
go.
in Vasco?
No.
It's Chichini.
Sunset.
Okay. Vasco has to be strengthened, and that
Yeah.
Mendinat, what's his name?
Mehendiratha.
He's a good guy. We could encourage him to strengthen that.
Yeah.
But in North, there is nobody.
Oh, we don't know if at all
I
there
beg
is
to,
somebody.
disagree, because the IMA Bardes, has done quite a lot of work during the COVID crisis.
No.
And wait,
Yeah.
that was the time when we all got together, I felt, and gelled. And I think this is the time, you have to take advantage of this gelling to put forth this idea that we want everybody to come on board. And if
Yes.
IMA is the vehicle that you can utilize, please do it, because
Yes.
everybody is now willing and wanting to do. And this is one of the advantages of this COVID crisis.
IMO has assured me all the support, so I'm very happy about that. So, Dr. Rajesh, as a private practitioner, what could be the challenge for a doctor to come on board? Or is there any hassle, or it will be?
I don't think there's any hassle, because see, at least in South Goa, as far as for me and more of my colleagues, we all report most of the cases. Even the rarest of rare cases is always reported.
Okay.
We had we have always have a Dr. Edwin has been called many times into our clinical meetings. We used to have every month clinical meetings. Now because of COVID it has come, but South Goa people are very, very cooperative.
So it should be a
and that
walkthrough
is
for us.
the only thing
It
should be anonymous reporting, like in tuberculosis. We will not be able to give you the
No,
name,
client.
age,
They don't want client details.
They want the client details.
No, because that is for 6 months. No, we as a lifelong, and we are also
because
very
the
much
patient come to us because they don't
confidentiality is the thing that we have to
what
uphold.
we may give you something called anonymous reporting, wherein the patient's age may be given, his symptoms may be given, and what treatment schedule is taking, and what is his CD4 count or viral load. That I think is a very acceptable way to report.
Okay.
And that should be. And one thing we should remember, I want to tell all my other colleagues from the medical fraternity is treating HIV is very, very, it gives you a great satisfaction. I'll just tell you one small anecdote. We had one lady. She was a teacher by occupation, and she got married outside Goa. That means somewhere Hubli. And after she got married, she left a job here and she went there. Within 1 or 3 months, she started noticing that husband was getting repeated fevers, cough, multiple infections. And at that time, it was after 4 months, she noticed that the husband was positive. And those days, I don't know what had happened, but within 6 months, the husband died. And she came back to Goa. She came back again. It's a Orthodox family. Their relatives didn't want to take her to the NACO center. She was tested positive, and she started losing weight. And one of her brother, who was my patient when I was in ASI, he brought her here to my clinic. We concealed her, and we found that this was the situation. I am also attached to 2 or 3 NGOs. With the help of an NGO, we tried to give her a job, one of the teaching. She did her DED after coming back to Goa, She got a job. She was started on ART. And very important thing is that by that time she had a pneumocystic carinae pneumonia that was treated. And as the job continued, I'll tell you, this is now the twist in the story. One of her colleague fell in love with her. He knew her history. He knew that her first husband died of HIV and she is positive. Then she brought her prospective groom to me. So I told him the pros and cons, whatever thing. He says, no, doesn't mind. And he had heard a lot about you now, pre-exposure prophylaxis. So that's why I told you this story.
Yes.
So in that time, the Truvida, that is the tenofovir with emcetrabine, had just come in the market.
Okay.
So we concealed him, and then he married her. He took the pre-exposure prophylaxis, and luckily they were blessed with a son. And both are now, he's now around 9 years that the things are going on. So it's not that HIV, I always give this example to my patient, that HIV means not the end of the life. You still have this, and you must really, I should really appreciate that boy who stood by against his family. He says, no, I will get married to this girl. And he read a lot of research. In fact, he was the first one who told me, Doctor, why should not I take a pre-exposure prophylaxis. And that's how the things
Yeah, I know this
work.
concept is fairly new, and I think NACO has not.
NACO, I don't know whether you all
NACO
are
has
having
said to do.
Yeah.
We have given one more patient through our OPD and they have conceived. Again,
Okay.
the child born is negative.
Yeah.
But only thing is that the combination drug they have to buy from outside.
Yes,
It is-
tenofovir with emcetrozine.
It is not
Okay,
available.
it's not available
Distributed
in the
out.
NACO
It's a
guidelines.
bit slightly costlier, but and
But
you
it's
have to
worth
stop.
it. 4 weeks they take.
Even the sex workers want to take it because we continuously monitor the
Yes,
sex
yes.
workers
But the
every 6
problem with
monthly.
this drug,
So they
tenofovir,
know
is
they are
that-
always at a high risk for getting HIV.
Yes.
So it is
Problem with
advocated
there
for
are
them
two
as well.
problems with this drug. Tenofovir can cause renal dysfunction.
Yeah, renal
Yeah.
So you have to check this patient every 6 months. We tell them every
So
third
that's why
month
you
creatinine has to be
can't-
seen.
you cannot
You just
take
cannot over the board.
over the
Over
board.
the board. Okay.
And we also give this pre-exposure prophylaxis those people who share needles. Now the things have come up in South Goa. I will be very surprised to note that earlier this needle sharing has started. That's
DCG
drug.
now NACO has provided for
Provided,
us,
yeah,
and they
but-
have changed. They are going to change over
Because the
from TLE to TLD also.
post-exposure prophylaxis, the
So
best drug
it's
is
going to
best
happen.
combination.
So-
If you ask the WHO or this, best combination is raltegravir 400 milligram with dolutegravir 50 milligram.
Oh.
This is the best combination.
So nice, happy endings,
it's
Doctor.
every
You,
year.
your people take
No,
the treatment from the private.
I also have a sad ending also. I remember of a man, another healthcare worker. After infection, he started, and went into a G6, was given that time TLE was not given. It was zidovudine, lamivudine with efavirenz. These were the drugs which was earlier. This drug was given. This man continued to take the drug, and then something probably happened to him. Maybe he went into depression or some family problem. He stopped the drug, developed multiple opportunistic infection, and that is the time when we sent for ACTH. ACTH came showing he had a Addison's disease, and one of the cause of Addison's disease in them was histoplasmosis, and then the biopsy proved histoplasmosis. But by bad luck, we lost him. So there are also sad endings for him.
Okay. So we have heard perspectives from the government sector, the private sector, the NTEP program. Madam, what would the final remarks of this conference?
One sentence I have. I think today's discussion has enabled us to realize that we can all collaborate. Whether you're in government, whether you're in private, whether you're like me, a retired person, but using the community and all other services, we need to collaborate, means work together. We also need to network. We need to find out what more we can do together to improve the outcomes.
Correct.
And GSAC should be there to coordinate
It's a pilot.
responsibly all this work so that at least as a state Goa can be led forward in unity.
Correct. Yeah.
All right, and that's the only way I think we will be able to write our success story.
Yes. And now the World AIDS Day is soon approaching on the 1st of December. And this year's theme I want to share with you is Global Solidarity,
Wow.
Shared Responsibility. And
I
Madam
didn't know
has
that.
summed it up so well that it's the community, doctors or non-doctors who have to come together, join hands, and then we can fight the HIV epidemic more
Surely.
effectively. Thank you, doctors, so much. For all of you all are very busy in your own field of work, but you took so much time, so much trouble to read up, to update the whole society as whole, like, what are the needs, what can be done and how it can be done. So thank you once again. I also thank the CCR TV for being very supportive and giving us this time and space to hold this program here. My GSEX team who have been all the time telling Madam what I should be doing next. So they have been also very supportive. Thank you. Stay safe. God bless.
Thank you.
Thank you.